Greetings and welcome to the next installment of the Quality Insights podcast series for healthcare professionals. My name is Joe Pinto and I'm a practice transformation specialist with Quality Insights, working in Pennsylvania with multiple practices in various specialties on several state and federal projects. Our topic for discussion today will be on the utilization of the PRAPARE tool and addressing social determinants of health and the important role that SDOH plays in their care. So with that, I'd like to introduce my co-host for today's show, Lamartz Brown. Lamartz is also a practice transformation specialist with Quality Insights, working on various projects in both Delaware and Pennsylvania. Welcome to the podcast, Lamartz.
Thank you, Joe.
And with that, I would like to introduce our guests joining us today. We have two health delivery experts with the Wright Center for Community Health and its affiliate entity, the Wright Center for Graduate Medicine, Medical Education, located in Scranton, Pennsylvania. They serve the urban and rural populations throughout northeastern Pennsylvania. Amanda Vommaro serves as the Director of Patient-Centered Services and Outreach and is Co-Director of Patient and Community Engagement. In this leadership position, she oversees the community health workers. Amanda has been with the organization for a little over a year and a half, starting as a community care coordinator. During her time with the Wright Center, she has assisted the geriatric patients with community resources for home modification so they can remain safe in their homes. While leading the community health workers, she helps facilitate patients' social, economic, and physiological needs. Amanda is also fluent in English, Portuguese, and Spanish. Walter Wanas is a registered and licensed dietitian and nutritionist and currently serves as the Director of Lifestyle Modification and Preventative Medicine for the Wright Center for Community Health and its affiliate entity, the Wright Center for Graduate Medical Education. Prior to joining the Wright Center, Walter served as the nutrition manager at Reading Hospital Rehabilitation in Wyomissing, Pennsylvania, where he was part of its leadership team and oversaw patient and employee experiences. Welcome to the podcast, Amanda and Walter.
Thank you.
Thanks, Joe. Thanks for having us. We're glad to be here.
Terrific. Now, before we dive into the show today, I just want to give everyone a brief overview of what exactly is meant by social determinants of health. SDOH is the acronym that we use for social determinants of health, and they are defined as the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And so with that, the first question that we have to open up the podcast session today is going to be for Walter. Walter, can you please explain to our audience the work that you do with the Wright Center and how you address social determinants of health within your practices?
Sure, Joe. What my job is at the Wright Center, I work in our lifestyle medicine program. And lifestyle medicine is really looking at medicine from disease prevention point of view. So what we try to do is help prevent people from getting diseases in the first place. And then if somebody has a chronic disease, we really look at how do we improve them through lifestyle changes, and can we reverse some of the diseases that we're seeing? A good example is type 2 diabetes, which you're very familiar with, Joe, where we're trying to, reduce the incidence of diabetes, but especially type 2. But we also know that by lifestyle changes, by weight loss, by exercise, we can actually get people back to a normal metabolic state where the diabetes can sort of they go away, where they're no longer a type 2 diabetic. So that's what lifestyle medicine is. It's really looking at the whole person and looking at it from a preventative standpoint of medicine instead of treating a chronic condition already. Now, at the Wright Center, what I'm privileged to be working at is there's three of us or three other providers that specialize in lifestyle medicine. Two of them are also board certified in obesity management. which is fairly a newer certification board. And that specializes in the disease of obesity and the latest training on managing and helping to lose weight. So it's really great to work with these three other people. Now, when we're looking at lifestyle medicine and even at the Wright Center, where this SDOH becomes so important is in order to really know a patient and to accurately diagnose them and set up a plan of care, we really need to know what's going on with the whole patient. So this is why we talk about, whole care for the person. We need to know what's going on with them. And then, Joe, it goes back to Maslow's hierarchy of needs. That we need to make sure people have the basics before we can move on even, further. So that's where the SDOH comes in handy, is it really gives us information that we might otherwise not have that could really affect their overall care.
Wow. Thank you, Walter, for sharing that explanation and the great work that you continue to do within your practices. This next question is for Amanda. Amanda, we want to know a little bit more about the PRAPARE screening. So what is a PRAPARE screening and what does PRAPARE measure?
So the PRAPARE screening is pretty much the protocol for responding to and assessing patients' assets, risks, and experiences. It is a nationally recognized standard patient social risk assessment protocol. It addresses the social determinants of health for our patients and the population level. It breaks it down to what the patient needs are, like you can see on the SDOH that you have with you right there. It addresses their housing situation. It addresses their employment, their economics, if they're able to get medication, insurance, transportation. It addresses their overall needs.
Okay, so what are the next steps after the patient answered these questions on the PRAPARE screening?
So once the patient answers those questions, it gets directed back to the community health workers, where the community health workers will then go into the exam room with the patient, or if the patient is no longer in the building, we'll reach out to the patient, either schedule a time to meet with the patient or go over it on the phone with the patient based on what the patient prefers. And we'll go over the positive SDOHs. We'll go over if the patient stated that they need assistance with housing, that they don't feel secure at home, or they are scared of losing their house. We'll go over options in the community, which would be then signing them up for public housing. If they have already signed up for public housing and they actually can't afford their rent, would be getting them set up with rental assistance in the community, different organizations that will help them pay for those assistance.
Terrific. And Amanda, how does SDOH coincide with the work that the Wright Center is doing, specifically focusing on hypertension and diabetes? How does SDOH overlap with these conditions?
So the SDOH is a screening tool that we use to focus on barriers to care. For example, like I mentioned, food, clothing, medication, transportation, housing, and insurance. So in order for a patient to take care of their chronic medical needs, like for example, diabetes, hypertension, they have to first take care of their social needs. So if a patient comes in and fills out the SDOH and they state that they don't have the means to pay for the medication, but the provider is prescribing them insulin, they're not going to go out and get it. That's where we then come in. The SDOH, once they complete the SDOH, they'll put, I need assistance with paying for my medication. Because a lot of times the patients don't feel comfortable telling the provider, I can't afford my medication. They're shy about it. So we'll go in, we'll speak to them and we'll say, okay, you can't afford this type of brand of medication, but there's this type of insulin. Or the patient somehow falls in the donut hole where they have insurance, but it's too much for them to pay for. So then we'll go out to like the manufacturer programs that are out there, and we'll see which or a program is out there that can help the patient pay for that insulin. And then at times we'll get samples of medications to assist the patients with.
Excellent. And I know those that are viewing the podcast, the visual portion of it, can see that we have a copy of exactly what the Prepare tool looks like through a couple of example screenshots on your screen. So Amanda, looking at the Prepare tool that we have in front of us here, do you ask all patients the questions, all of the questions that are listed on the Prepare tool? And if not, how do you identify which patients you actually engage?
So the way we do work with a SDOH is every 6 months, or if the patient is new to our organization, they fill out that SDOH. So if the patient is new to the organization, on their first visit, we'll go walk in, we'll present ourselves, we'll say who we are, and we'll go over all those questions. There is a way as you're talking to the patient, and once you've been a community health worker for a little bit longer, you get used to like who would be a positive for a certain question, who would be a negative for a certain question. So for example, when we're doing the housing questions, we just go over, how do you feel? How's everything? How's home? Do you feel safe at home? Like we just put it together in like one question to fill out those 3 questions. If they're safe at home, if they feel their house is secure, if they're not worried about losing it. We asked the questions of like, overall in the past year, have you by any chance needed any of these that you were not able to get to? Food, utilities, phone, medicine, clothing. And then based on the patient, we'll also mention childcare or not. And then that's how we pretty much go through the questions with the patients.
And those questions are very important when looking at the Prepare tool. But let's shift a little bit and let's talk about the COVID pandemic. I know a lot of times when we talk about COVID, everybody frown because it was a time when, things slowed down, things were not going the way we planned it. But how much of an impact did the COVID pandemic have on the SDOH data being collected in the practices?
So during COVID, shockingly, I should say, there were a lot of more resources available to the community. Resources that before we did not have became available due to the pandemic because people weren't working. So you weren't able to afford rent. You weren't able to afford food. You weren't able to afford your car payments. So a lot of more resources came out during that time. Like for example, housing, you weren't allowed to get evicted during a certain period. Food, medical assistance, people were getting accepted. I'm not gonna say easier, but the lenience to it was wider. Food stamps, people went from receiving $100 to receiving $300, $400 a month. So there were more assistance out there. And due to that, our number of SDOHs started to increase positively and negatively. Why? Because one person would tell the other, oh, I'm currently set up with this. So the other person would come in and be like, hi, can I get set up with this also? So our number of positive screens during COVID increased.
Okay, so COVID wasn't, bad after all. We went through a lot during the COVID pandemic, but at least, the patients and the clients that, you came across, at least they had some resources that they can, make their lives a little bit easier and better. So speaking of resources, and you spoke to it a little bit, but are the patients being referred to resources? And if you can, just give a little bit of a breakdown of what resources they were referred to.
So for example, transportation. When it comes to transportation, we refer our patients to, depending on the county they live in, either Luzerne County. If they're from Luzerne, we'll refer them to Luzerne County Public Transportation. Lackawanna will do Colts. Susquehanna, Pike will do Trehab. Transportation, we'll fill out the applications with the patient based on if they're set up with medical assistance, based on their age and based on their need, because there's 3 different types of applications within each organization that you would be able to put a patient in. For housing, we would set them up with Lackawanna County Housing or we would go through Section 8, or we'd set them up with ERAP applications. United Neighborhood is another one that we tend to go to a lot because they have housing counselors for patients where they're actually able to assist patients not only in the county, but outside the county, doing applications for housing, going through rental applications, looking at private housing, which would be like private apartments that you can just use Section 8 for. Those are some of the assistance that we would give to patients in those two departments.
Excellent, thorough information, Amanda. And you know, you brought up the counties that you're working in with Lackawanna and Luzerne. Just to follow up on your answer, for those that are not familiar with the geographical location and the counties that your coverage area encompasses here in northeastern Pennsylvania, can you tell the viewers which counties you're actually working in, the communities that the Wright Center serves, so they have an idea where you're located outside of just, you know, the Scranton area?
So we work with Lackawanna County, Luzerne County, Pike County, Monroe County, Susquehanna.
I think you covered them all
Yeah.
right now. As of right now.
Yeah, as of right now, those are the 5 that I could think of from the top of my head that I work with daily.
And Wayne County.
Wayne County,
Oh,
there
my
you go. We
goodness.
forgot about one. There you go.
Figured Joe would know
Yeah.
that one.
That's my old background,
There you go. Wayne
backyard.
County,
Yeah.
yes.
Okay, so now we're going to shift a little bit towards the data side of things. And Walter, this next question is specific for you. As you know, data is so critical for assessing the successes and the barriers to any program. So how much help do you see from the various EHR systems when it comes to providing the practices with reporting capabilities, especially specifically related to social determinants of health data?
Great question, Joe. I was around before we had the electronic health record. So I remember back in the day where everything was done on paper and how difficult it is, and where only one person could be in a chart at a time because it was actually a physical chart. Now, since the electronic medical record came about, it allows us to capture information in real timing. So we can see a lot of information very quickly, and we can see multiple information, meaning we can see lab work, we can see x-ray reports, we can see if somebody was out to a specialist, what their recommendations are, medications we could see when they were refilled. So it allows us to have all this information really very quickly. So what it does is it allows for a very accurate assessment. And again, it helps improve the standard of care or the patient plan of care that we format for them. So this is really, so it's been really groundbreaking since this came about. Now, in the beginning, it was a little tough because everybody was learning. You go from a paper system to electronic, and then we're also fine tuning it over time, because in the beginning, it's not doing the functions we wanted it to. So as time progressed, we kept refining it, where it's so much different now than it was even 2 or 3 years ago. And we keep finding those refinements in there. The hardest thing with the electronic medical record is that there's not just one system. There's multiple systems out there, and usually hospital systems will go on a certain system. The big ones, Epic, Cerner's, are probably 2 of the bigger ones. We use a system here called Medit. So what happens is these don't really communicate with each other. We would like them to, but you know, they're both built totally differently the way they collect information. So sometimes if we have a patient who's from the outside, a brand new patient where we're getting their medical records, we need to upload that usually manually into our system to get all that information in there. And the same with the SDOH, we got to do it manually. But what we want to do is before we even see the patient, we want to make sure we have their medical records, because it's really important to see where are they at, where did the last provider leave them off at, so we have a real good starting point on where we need to go. And that's why the social determinants of health is so important, because it gives us a lot of background information that we wouldn't have had, especially if they're brand new and we didn't have them fill out the form yet. And we want to see what the plan of care was for that person. A big thing is if somebody's discharged from the hospital and, you know, what was the plan of care for them? And if we realize, wow, you know what, if we don't have the right resources for them, or they didn't get the right resources, they can go right back in that hospital system again, in that evolving circle. Did they get the care that they needed when they were at home? And now I will say medicine is changing, where we're looking at how do we keep people healthy? How do we keep them out of the hospital? How do we do this continuum of care? And that's why Amanda's position is so important, because we want to look at what are the barriers to healthcare that people are experiencing, and let's look at how can we intervene there. The electronic medical record is part of it, and it's a very good part and very helpful. But the good thing is Amanda can put information right in there. And we have the ability, we call it triage doctors if we need something in real time. So we don't have to wait a day or 2 days or hours. So we can do things in real time, such as if a medication isn't covered. All right, can we get a different medication covered and triage the physician, boom. So while we have the person on the phone, we could do that in real timing. So that's what really has transformed medicine. And I continue as we learn more. I think there'll be more interactive tools, which probably be the next step that we start seeing.
Yes, Walter, I think the more you learn about, the PRAPARE Tool, and when we look at the electronic medical records, a lot of time change is not something that, is always welcome. But I think the electronic medical record does help, like you said, in real time. So I do appreciate that about the electronic medical record. But Walter, why is it important to measure the determinants of health?
Oh, you always have to measure, because we want to find out is the patient improving or are they not improving? Are they going the other way? So when we look at metrics, and metrics are used for every industry, right? Healthcare, no different. Healthcare, maybe it's even more important, because we want to find out, is this plan of care that we want to be more accurate and more identified with the patient, and is what our plan of care, is it working? And this is why we measure. And at your organization, we know how important it is for the blood pressure readings and for the hemoglobin A1Cs. And we track to see, is there improvement over time? And are our interventions working? Because if we're not seeing improvement, is it the result of our interventions, or is there some underlying issues? And this goes back to the SDOH, because as a managing, if a person doesn't have money for a medication, or they have to decide it's either food or medicine, or do I take half of my medicine so it lasts me longer? And these are all real experiences we see almost on a daily basis. So they have to make that decision. And by measuring, if we see something that doesn't look right, then we could ask those questions, just like we would with the social determinants of health, to find out what is going on. And when I'm with providers, if we see that happening, that's where we call Amanda in to say, hey, listen, we got to find out what's going on here, because maybe they need a separate program. We have a 340B program that helps people with medications, another program that's out there. So what it does, it allows us to determine what services they may need. We get in touch with Amanda or some other one of our resources, to find out what it is that that person needs. So this goes back to treating the whole person, and it goes back to meeting them at their needs levels where they are, which is quite different from when I first started in medicine. So it's really nice that we look at the whole person, and we look at all these other factors that we wouldn't have known about if we didn't have the SDOH. Because we here at the Wright Center, we're also medical, we provide a lot of resident training. So these residents are coming out here, this SDOH is brand new to them. And they're experiencing, wow, what are all these other factors in medicine that I didn't learn about? So they're getting real life training here. And that's what we do too. We're finding out stuff every day. I find out so much resources from Amanda that's very helpful to know how we can treat the whole person. And another thing was mentioned earlier, just with telemedicine being available. And that was one of the results from COVID, was the allowing for telemedicine, which has really helped tremendously. And also using that as a new tool in case if somebody has problems with transportation. All right, we have this new tool we could use and it might be appropriate here. So what we do is sometimes from these traumatic events, we find out new ways to put new interventions in. And we do that by metrics. And this is why it's so important in metrics is our plan working? If it's not working, what's going on? And asking that question, why? and then figuring out what can we do. And learning as a group, we find that is so beneficial because what are other facilities doing? So we don't have to reinvent the wheel because somebody's trying to experience it somewhere else and we could learn from them. And that's why it's so good to keep information flowing, because you find out what other people have already experienced and how they're dealing with it.
Yes, and I can say this is one of the reasons why we do podcasts and webinars like this, so that, other physicians, other practices, other hospitals, can learn and see what other people are doing and kind of learn from it and get more information and be educated about it. So this is definitely why we do podcasts like this. Well, so I have one more question for you before I have a question for Amanda. How is data being tracked over time?
Actually, what we do is we have different systems within the medical record, electronic medical record. So actually, for one of the things we do for quality insights, we look at, all right, we're tracking blood pressure levels, we're tracking hemoglobin A1Cs. So we have them set up in the electronic medical record. So we know that when should we do a new hemoglobin A1C. So it sort of flags us to know, oh, it's time for a new one, which is great because it's a reminder that, hey, it's 3 months or it's 6 months out, or if we change the medication to get another one done. And then the system will track it for us, however we put the, however we set it up to do. So once we put the logic in how we want it, then we set it up. So then we can run reports that could be done weekly, monthly, to see how are our patients doing. And that's a big thing we do is overall hemoglobin A1Cs. How as a facility are we doing with our patients? And what's interesting about that is when we spent a lot of time months ago, or maybe even a year ago, trying to figure out how come our A1Cs weren't coming down, right? We're doing all these interventions. And when you do a deep dive, we found out quite a few things. Is some of these people haven't been here in a while, so their data keeps flowing in and they're skewing our numbers. But we wouldn't have known that unless we did a deep dive. But what we did do then is let's call those patients. Let's see if we can get them in there for an appointment. So it really gave us the opportunity then to reach out to these patients and get them in scheduled for a visit. So it was a good way to find out who's falling through the cracks. And then also too is get us really put it on our radar screen that, wow, our levels are high. So we really got to fine tune, break it down. And also too is call people for the regular wellness appointment. One thing with COVID is people were missing their annual wellness appointments. So we were able to get back on track with that. So that's why looking at this data and recording it is really so important. And then we find out we can do it for many things, not just labs, but for certain diagnoses, especially if a new treatment or a new medication comes out, we can run, all right, let's see who has this diagnosis. When are they coming back in? Do we reach out to them telling about, say, maybe there's a new medication or a new approach? Or we'll flag them so when they're coming in. So, all right, let's talk to them about this new approach or new intervention that came online. So that's the amazing thing is that we can, instead of trying to go paper-wise like the old days, and try, which would be almost impossible, we can do it in real timing now, which is fairly easy. And this is how data improves patient care, and it improves our plan of care for a patient. And that's what we want to really do. We want to make sure our plan of care is accurate for the patient and it's as good as it could possibly be to give the patient the best outcome.
Yes, and that's what we want to do is we want to give the patient the best outcome. Amanda, I have a question for you. Tell us about the PRAPARE tool that you use and other tools that you utilize when working with your practices.
The PRAPARE tool that we use is the SDOH, which is our social determinants of health. Once the patient does complete it, we'll go out and we'll reach out to the community for resources based on patient's location and their needs. Those are the other tools we use, and we use them a lot, is our resources in the community. Making sure that, like, if based on what the patient needs are, we're able to completely help them. Going back to housing, when the patient tests positive for insecure housing, needing assistance with paying rent, we go to the community, we go to United Neighborhood, we go to Catholic Social Services, we go to encouragement, the Community for Encouragement in NEPA. Like those are some of the organizations we'll go back to. Applications. We do a lot of applications with ERAP. St. Francis here and Friends of the Poor will help patients with paying rent, will help patients with getting them furniture, with utilities. So those are some of the tools that we use greatly when we go back and look at what the patient needs once they do complete our SDOH.
Fantastic. And Walter, have the providers shown any hesitancy in using ICD-10 codes with positive responses when it pertains to SDOH data when they use the PRAPARE tool?
Good question, Joe. Usually, I haven't seen a hesitancy to use the code. It's more of the knowledge base on what these codes are used for and when to properly use them. Again, being a teaching facility, we're getting one group of residents are graduating this week and going out to the world where where they're licensed and going to be board certified in their specialty, and they're out on their own or in a group. And then we have another group coming in who are brand new. So teaching them not only the SDOH, but also too is the ICD-10 codes to use and when's appropriate to use them. And also too is following up with certain questions if we're not sure about. So they're learning that it might not be a medical side, but they're learning that those other sides of providing care that's so important to the patient, and really trying to do, again, diving into certain questions or information to find out, does somebody really need help? As Amanda was saying earlier, sometimes, patients might be intimidated or they might not want to ask, they could be embarrassed. Could be a variety of factors. And our job is to not only help them feel at ease, but also too is help get this information out from them so we can give them the best treatment possible. So I wouldn't say a hesitancy for using the codes. It's when to use them correctly. And when you get in those situations where do they need housing? They're staying with a friend, but is that considered needing housing or not needing housing? Or they may have a benefit plan that provides these medicines, but do they need that money for other things? So it's those gray areas that we try to help them with in how to record them. So I would say more or less the knowledge. And since we are teaching, it's ongoing. So the education is ongoing, and it always needs to be ongoing because we always have a new group, and then they're doing rotations in. And after time, I've been fortunate. I've been here almost 2 years to see how a physician can grow in a year's time based on what they see in the clinic. So they can see the inpatients in a hospital setting, which they do in doing the rotation, but then in the outpatient, how do you look at all those other factors that you're encountering, especially from the SDOH, which really is, to me, the driving force, all these other that are going to affect their health and outcomes.
Yes. Thank you for explaining that, Walter. Amanda, we're going to come back around to you. What are some of the challenges or barriers to care that you see in the various communities in which your practices are located? Are there racial and economic disparities prevalent in most of the communities?
Some of the barriers we see, and it goes back to what we just spoke about, would be the bigger ones would be transportation and housing. Transportation would mainly be because of how it's set up. We depend on public transportation for a lot of our patients to get to our facilities. And at times our facility, for example, in Holly, it's a rural community. So transportation out there is harder. It's not like Scranton or Mid-Valley or Kingston, where it's more city-like and we have easier transportations, plus is flowing in quite often. Some way that we have overcome that barrier is we've now provide our patients with Uber rides and taxis, because what's been happening is some of our patients require an appointment less than 24 hours or same day. They call and we get them in within the next few hours, and public transportation requires 48-hour notice. We can't do that if the patient's coming in within the next 2-3 hours. So we'll provide transportation for them. Housing being another one. housing is a big barrier because in most counties currently, housing, public housing is actually closed. The wait list, you can't even put your name on it. And the ones that aren't closed, the wait list is so long that they tell you realistically, you're probably looking at a year out. So,
Yes, and a lot of times when we are looking at housing, a lot of our patients, our clients, they want, placement right away. And sometimes with housing, that is not available. So it is something that, is very relevant to, using something like the PRAPARE tool to identify exactly, what they need. And when we look at the PRAPARE tool, Walter, why should other practices and hospitals actually use the PRAPARE tool?
You really should use it because it really helps with that continuum of care for the patient. We don't want people to fall through the cracks. And this is just like when I mentioned earlier, when we're getting a new patient and we have a new record coming in, is we're looking for that PRAPARE tool because we want to find out what barriers have they, come across. Is there any positives in there to make sure was it addressed or not? Are we seeing them again because maybe something, fell through the cracks with their care? So that's why it's so important for different organizations to use it, especially medical organizations. So this way, it's just like an assessment. I look at it as being, an assessment of the patient. So this way, we have a starting point for the patient. So we don't have to go back or make sure we offering the services that they need. As we are just mentioning with some of the barriers that we experience, one is behavioral health. Behavioral health is huge, especially since COVID hit. It really caused a lot more depression, more suicides. So this whole list of different things that came about because of COVID, and then we're trying to rush now to get people treatment. So this is what we're seeing a lot too, is trying to get people to see treatment, and how do you do it? Just an example, we were able to increase our psychiatric residency because of this. However, that's going to take a long time before they get out into community. So it takes a while, but the whole thing is that we have to, sort of think ahead. What are we going to experience, or what are we experience to make sure that, somehow we can intervene and at least have a plan going forward.
Great feedback, Walter, and thank you for that. And so as we begin to wind this session down, this question is going to go out to the both of you, to Walter and Amanda. So what have you learned after using PRAPARE?
I can say that doing what I do here as a certified community health worker and having been in this role for almost 2 years now, the great amount of unmet needs in our community and the surrounding community is greater than we can imagine.
Okay, and then what strategies would you use to determine just how social determinants influence the individual's health?
The strategy to assess and direct patients with the appropriate tools they need to navigate the healthcare system.
Okay, great. And then Walter, are there any specific success stories from the Wright Center, specifically as they might pertain to federally qualified health centers or rural health centers, that you could share with our audience?
Yeah, and actually going back to the last question you were asking with Amanda, is one of the things we actually get involved with is those in most need. Especially we've done vaccine clinics down in the Pittston area for school-age children that were going to go to school and they couldn't get in because there's no vaccinations. We were doing COVID vaccinations to high-rise for elderly because they really couldn't get out or it really wasn't safe. So we would just go on the road and do that. Recently, we were just in an area where we were providing to the homeless who haven't had care in we don't know how many years, and looking at, okay, just regular assessments, any kind of medications we can get them on, any resources. So the whole thing is sometimes going out to the community and reaching them, the ones that, groups that can't get to us, or have so many barriers that coming to a facility is not going to happen. So the amazing thing is seeing those stories, it makes you feel good. And then also too, realizing like Amanda's job and these other important aspects are really so important. When I moved back to the area, I didn't realize either how much of a need is there, you know, and how people are struggling so much. It caught me off guard, especially seeing patients who need so much resources, and how if they don't get the resources, how it affects their health and then their children's health. And that whole cycle continues. So the whole idea is provide the services now that we can, because it makes a big difference. And when you see those, when you see the medical van that we have going and offering these services, and how appreciative people are, I mean, it's just such a great feeling.
Yes, it's such a great feeling to see that. So one last question, Amanda, what advice or encouragement would you give to practices that haven't yet implemented the use of the PRAPARE tool within their practices that are currently reviewing the benefits of doing so?
The encouragement and advice I would give them would be, you can't treat a patient's medical needs if their basic social needs aren't met. So no matter how much you try, like Walter said, to make sure that their hemoglobin A1C are down, that their blood pressure are down, that they are being treated correctly, if you're not going to go back to the beginning and treat the basics, what you're doing is going nowhere. You're not going to be able to accomplish what you want.
It's such a part of the overall assessment of the patient that without it, you're not doing a full assessment. You really aren't.
I think for you to start treating the patient correctly, you have to start at the basic level, which is by doing the SDOH, because you're meeting the patient where they're at, what their true needs are. Once you treat them there, you're able to treat them medically.
Fantastic information. I want to thank the both of you for participating on our podcast session today. And if you'd like to know more, those of you that are attending, if you'd like to know more about the Wright Center and the programs that they provide to the communities that they serve, you can check them out on the web at their web link that's provided on your screen. If you're only following this podcast through the audio version, their address is www.thewrightcenter, that's all one word, .org. And that's all information pertaining to the programs at the Wright Center for Community Health and the Wright Center for Graduate Medical Education. So, and also for those of you that are in attendance, we do invite you to please share the link to this podcast and the educational resources that are available to your staff and colleagues. You can find it at the website link on your screen. Will be made available through our website resource library. And we hope that everyone enjoyed today's session and that you will join us again as Quality Insights provides another engaging podcast session sometime in the near future, and we discuss the topics that are important and impact healthcare today. So until then, so long, everyone.